Robert Siciliano, and I will discuss pharmacologic management of pulmonary tuberculosis. So how do we treat TB? So Mycobacterium tuberculosis is resistant to most antibiotic. First, because it grows slower than other bacteria. So antibiotics that are most active to rapidly growing bacteria are relatively ineffective. Next, it is dormant, thus making it resistant to many drugs, or it is killed very slowly. It has a thick lipid-rich membrane. Also, it is an intracellular pathogens. Therefore, it is inaccessible to drugs that penetrates this cell poorly. And last, it has the ability to develop resistance. So combination of two or more drugs are required to overcome these obstacles and to prevent emergence of resistance during the course of the therapy. So how do we treat laboratory confirmed drug susceptible active pulmonary tuberculosis? So first, let us review the first line anti-TB agents. So on your left, on the yellow box, here's your first line TB agent. So isoniazid, rifampicin, ethambutol, and pyrazinamide. While on your right, that is our second line agents. So it is reserved if the first line anti-TB agent is ineffective or it develops any adverse drug reaction. So our second line agent, amikacin, aminosalicylic acid, bedaquiline, capreomycin, cycloserine, etonamide, levofloxacin, linosilin, moxifloxacin, rifabutin, rifapentin, and streptomycin. So H and R are the most active drug. So isoniazid, H, rifampicin, R are the most active drugs. So a combination of these, if this will be administered for 9 months, it will have a cure rate of 95 to 98%. Then addition of pyrazinamide during the intensive phase, it allows the duration to be shortened to 6 months without the loss of efficacy. So ethambutol, it can be added to prevent resistance to isoniazid, rifampicin, or both. So in our case, the patient has a pulmonary active TB, so we can give the regimen 1. So based on the table, regimen 1 is composed of intensive phase and a continuous phase. So in the intensive phase, the treatment should be given for 2 months. It is composed of isoniazid, H, rifampicin, R, pyrazinamide, and ethambutol. So you will give daily this tablet for 2 months. Then after 2 months, you will proceed to continuous phase. So you will give HR or isoniazid and rifampicin daily for 4 months. So in intensive phase, it kills most tubercle bacilli, but most bacilli can survive longer. And intensive phase also prevents the emergence of drug resistance. It determines the ultimate outcome of the regimen. So kung may ma-develop ba na drug interaction or kung magre-respond yung patient sa treatment. So in the continuous phase, it kills remaining tubercle bacilli after the initial phase. So if the treatment is not continued long enough, the surviving bacteria may cause TB disease in the patient at the later time. So the National TB Program preferred the standard fixed dose regimen for drug susceptible TB. So here's the dosing for adults. So fixed dose combination drugs are convenient in terms of accessibility and adherence and are preferred especially in this programmatic setting. So what is fixed dose regimen? So it is one tablet. It is composed of four or 2 or 4 drugs or more drugs. So in the intensive phase, it is composed of 150 milligram of rifampicin, 75 milligrams of isoniazid, and 40 milligrams of pyrazinamide, and 275 milligrams of ethambutol. So based on the weight of the patient, which is 72.7, so as you can see on the table, you will give 5 tablets. So in the intensive phase, you will give 5 tablets of fixed dose regimen daily for 2 months. Then in the continuous phase, fixed dose of rifampicin and isoniazid, 5 tablets daily for 4 months. So another way is we can give single drug formulation. So single drug formulation it is indicated to those who experience adverse reaction or at risk for development of any drug reaction. Also with patients with comorbid condition requiring dose adjustments. Also, patients who are expected to have significant drug interaction. So that's our indication for single drug formulation. So as you can see on the um, right lower table box, so based on the patient's weight and the dosing of the drug, the patient will take 10 tablets daily if we will give the single drug formulation. So this is a pill burden to the patient. So 10 tablets a day can cause pill burden and promotes uh, poor adherence or compliance that can lead to poor treatment of the patient. So it is only indicated for patients who might develop any drug interaction. Next. So what is the expected adverse drug reaction? So it is divided to minor and major. So first, let us discuss minor. So minor drug interaction, our approach here is if any minor drug interaction will occur, our, we don't have to terminate the regimen. So we just have to treat the drug interaction. Like for example, if the patient develops gastrointestinal intolerance because of rifampicin, isoniazid, and pyrazinamide, we can give the patient the drugs with meals. Next is the patient develops any mild or localized skin reaction, we can give antihistamine. And also the expected drug reaction of orange colored urine for rifampicin, we can reassure the patient that it is harmless. Also, burning sensation in the feet due to peripheral neuropathy because of isoniazid. So remember, isoniazid promotes the excretion of pyridoxine or vitamin B6. So prophylactic administration of vitamin B6 will prevent this uh, drug reaction. Also, arthralgia due to hyperuricemia because of pyrazinamide, we can treat the hyperuricemia. Also, flu-like symptoms because of rifampicin, we can give antipyretics if flu-like symptoms will develop. A different approach in adverse major adverse drug reaction. So if any of these major drug interaction will develop, we need to stop all of the anti-TB agents immediately. So what are the major drug reaction? First, if the patient develops severe skin rash due to hypersensitivity to any drugs, jaundice due to hepatitis, to any drugs, especially isoniazid, rifampicin, and pyrazinamide. And next is impairment of visual acuity and color vision due to optic neuritis because of epatambitol, oliguria due to rifampicin, or even psychosis and convulsion due to isoniazid, and thrombocytopenia anemia, shock because of rifampicin. So any of this will happen, we will need to stop the medication immediately. But remember, we still have to treat the TB. So the introduction of anti-TB drug following adverse drug reaction. So here's the approach. So first, isoniazid. So if the drug reaction or the major drug reaction will happen, first we will introduce day 1 isoniazid in a 50 milligram. Then a stepwise increased dose will happen in day 2, 300 milligram, then full dose. Then, if no reaction will happen, we will add 75 milligram of rifampicin in day 1, then next 300 milligram. So we will observe in this stepwise manner if any drug interaction will happen. We will know the culprit of the reaction. Like for example, if the patient develops any hypersensitivity, then we apply the stepwise fashion, then we will know the culprit of the reaction. Then we can replace the offending drug from the second line drugs. Okay. So next. So how do we treat PTB in patients living with HIV? So it follows the same recommendation, but antiretroviral treatment or ART should be started in all TB patients living with HIV, regardless of CD4 cell count. Also, cotrimoxazole prophylaxis should be given at 80 milligrams to prevent any opportunistic bacteria. Also, sulfamethoxazole plus 160 milligram trimethoprim should be also given to prevent pneumocystis jirovecii pneumonia among patients living with HIV, regardless of CD4 count. So often the ART are delayed because of possible drug interaction between rifampicin and the antiretroviral drug. What are these reactions? So first is the IRIS, or immune reconstitution inflammatory syndrome, and drug interaction toxicities. But a delay in administration of ARTs will lead to AIDS-related increase in morbidity and mortality, as you can see in the picture. So a balance between early administration and late administration of ART should be optimal. So the National TB Program recommends that TB treatment should be initiated first, followed by ART as soon as possible within the first 8 weeks of the treatment. So that's the optimal that's the optimal time that we can give ART after the initiation of TB treatment. So first 8 weeks of treatment of anti-TB. And also, if with profound immunosuppression, like for example, if yung CD count is less than 50 cells, HIV positive PTB patients should receive ART within the first 2 weeks of initiating TB treatment. Next, the patient's liver function tests are slightly elevated. So in the case, the patient revealed a elevation in ALT, slight elevation. So first, let us define hepatotoxicity. So serum ALT level greater than 3 times the upper limit of normal in the presence of symptoms. So what are the symptoms of hepatotoxicity? Nausea, vomiting, and abdominal pain. So based on the case, the patient doesn't have any symptoms of hepatotoxicity. Also, hepatotoxicity is elevation of ALT more than 5 times the upper limit of normal in the absence of symptoms. So the patient doesn't fit the criteria for hepatotoxicity. So we can give the first line anti-TB drug. So yeah, if the patient or any patient will develop hepatotoxicity, all medication should be stopped immediately because this is a major drug reaction from TB drugs. So after normalization of ALT, less than twice the upper limit normal, resolution of clinical symptoms, we can stepwise reintroduce of the potentially hepatotoxic anti-TB drug. Yung katulad ng diniscuss ko kanina. But here, we may be starting with rifampicin with or without ethambutol. Second, followed by INH after 3 to 7 days, subsequently rechecking the enzymes or transaminases. Then all medication should be stopped immediately. Pyrazinamide should be permanently discontinued because the pyrazinamide is the most hepatotoxic among this first-line TB drug. So also, patient is diabetic. So regimen for TB among patients with diabetes is the same as the general population. Therefore, strict compliance is also needed for this patient. Also, glucose control for diabetic individuals with TB should be optimal. So the continuation phase of the treatment should be prolonged to 7 months instead of only 2 months. So 4 months rather. So a total of 9 months of therapy instead of 6 months only. So in diabetic patients, we should give the anti-TB drugs for a total period of 9 months. So for glucose control, or HbA1c more than 7, increases the risk of poor outcome and pwedeng mag-increase yung risk of relapse and poor treatment. So the general target in HbA1c of less than 7 and FBS of less than 100 milligrams per DL is our general target for this patient. So the patient in our case is slightly elevated of 7.2%. So the patient is uncontrolled. The patient has uncontrolled diabetes. So yeah. So rifampicin accelerates the metabolism of sulfonylureas and biguanides. Remember, in our case, the patient is taking metformin, which is a biguanide. So rifampicin will accelerate the metabolism of biguanides. Also, isoniazid antagonizes sulfonylureas, causing worsening of glycemic control. So the National TB program prescribed that insulin therapy will be a better option to achieve optimal glucose control. So once the patient is sputum or culture negative, and if the blood glucose level is acceptable, patient may shift from insulin therapy to oral hypoglycemic agent. So the insulin therapy will be a better option in case of patients with diabetes na iti-treat with PTB. So next, how do we manage interrupted treatment? So if less than 1 month of interruption, so we will continue the treatment and prolong to compensate the missed dose. But if the interruption of the therapy is more than 1 month but less than 2 months, we will do sputum microscopy. If it is negative, we will continue the treatment and prolong to compensate for missed dose. But after doing sputum microscopy and it turns out to be positive, if the therapy is taken by less than 5 months, continue the treatment and prolong to compensate the missed dose. But if the patient is positive for the smear and the therapy is taken for 5 months or more, then we will assign outcome as treatment failed. So if the interruption is more than 2 months, we will assign the patient's outcome as lost to follow-up. So how do we assess efficacy and efficacy of the treatment? So this is the schedule of sputum follow-up examination for PTB on drug-susceptible TB regimen. So new clinically diagnosed TB, so ang follow-up po ng sputum is the end of the intensive phase, which is after 2 months. Then, only if positive at the end of intensive phase, we will do a follow-up of sputum at the end of the 5th month and at the end of the treatment at the 6th month. So next is new bacteriologic confirmed tuberculosis. Same, we will do sputum smear at the end of the 2nd month, also at the end of the 5th month, and at the end of the 6th month or the treatment. So here's the treatment outcome for patients who will be treated by anti-TB agents. So first, the patient will be cured. So a patient with bacteriologically confirmed TB at the beginning of the treatment and who has been smear or culture negative in the last month of the treatment, and or at least one previous occasion in the continuous phase. So next is treatment complete. Ito yung patient na na-complete ng treatment without evidence or of failure but with no sputum smear negative result in the last month of the treatment. Also, treatment failed. Patient whose sputum smear or cultured is positive at 5 months or later during treatment. Also, treatment terminated because of evidence of additional acquired resistance. A patient for whom follow-up sputum examination was done and who does not show clinical improvement anytime during the treatment. Also, severe uncontrolled adverse drug reaction. Also, a treatment outcome, patient may die or died. A patient who dies for any reason during the course of the treatment. Also, lost to follow-up, yung patient whose treatment was interrupted for at least 2 consecutive months or patient diagnosed with active TB but wasn't started on treatment and not evaluated. Ito yung patients for whom no treatment outcome is assigned. This include patient na na-transfer to other facilities for continuation or treatment, but the final outcome was not determined. So here's the comparison of the first-line drug based on the efficacy, suitability, safety, and the cost. So first, efficacy. The rifampicin, I placed 3+, because it is the efficacy, the mechanism of action of rifampicin, it binds to the beta subunit of bacterial DNA-dependent RNA polymerase, and thereby it inhibits RNA synthesis. Next, isoniazid. It inhibits synthesis of mycolic acid, which is essential sa cell wall of the mycobacterium. So, yun. Next is pyrazinamide. I placed also 3+. It is a prodrug that will be converted to pyracinoic acid that will disrupt the mycobacterial cell wall or end membrane transport function. And last, ethambutol, the efficacy I placed 3 plus. So it is a cell wall, also a cell wall inhibitor. It inhibits mycobacterial arabinosyl transferase that is involved in the polymerization reaction of the cell wall. Therefore, it will disrupt the cell wall. Next, for the suitability, for rifampicin, it is indicated for the patient because patient is on is it has the patient has active PTB. So a combination of this drug with isoniazid will give you a cure rate of 98%. And rifampicin, I place it uh, 3 plus because it is well absorbed after oral administration, excreted mainly to the liver into the bile. You don't need to adjust it for renal or hepatic insufficiency, and it is distributed widely in the body fluids. So that's why I placed 3 plus. While the isoniazid, I placed 2 plus. Also, it is indicated for our patient because patient has a active PTB, and combination with rifampicin will give you a cure rate of 98%. It is absorbed in the GIT optimally with empty stomach. The peak concentration may be decreased by up to 50% with fatty meals. So we will advise the patient to limit fatty foods or avoid fatty foods when taking isoniazid. It is diffused readily into all body tissue, and metabolites and a small amount of unchanged drug are excreted in the urine. The dosage need not to be adjusted in renal failure. But it inhibits several cytochrome P450 enzyme, leading to increased concentration of such drug, phenytoin, carbamazepine, and benzodiazepine. Remember, the patient has a PRN benzodiazepine for her depression. That's why I placed only 2 plus for the suitability of isoniazid. So next is the pyrazinamide. So I placed plus 3 because also it is indicated for patient because additional of pyrazinamide will lessen or reduce the duration of the treatment from 9 months to 6 months without losing the efficacy of the therapy. Also, it is well absorbed in the GIT, and it is widely distributed in the body tissue, including inflamed meninges. It is metabolized by the liver, but metabolites are renally cleared. That's why I placed 3 plus for pyrazinamide's suitability. Next is ethambutol. It is indicated for patient because patient has active TB. It also prevents resistance to isoniazid, rifampicin, or both. It is well absorbed in the gut also, and it is excreted in the feces, and 50% unchanged from form in the urine. And ethambutol accumulates in renal failure, but the patient doesn't manifest any manifestation of renal failure. Next is for the safety. So in rifampicin, I placed 2 plus because it can cause harmless orange urine, occasionally causes hepatitis, flu-like symptoms, and acute tubular necrosis. So also it can cause drug interaction with sulfonylureas and biguanides, which subsequently lower the plasma level leading to hyperglycemia. So, but according to my previous discussion, the patient will be shifted to insulin therapy for optimal glucose control and also to avoid drug-to-drug interaction between biguanides and rifampicin. So, I placed only 2 plus for the safety of rifampicin. Next, isoniazid, I've only placed 1 plus because it can cause hepatitis, peripheral neuropathy, which is more common to happen to patients with DM, like in our patients. Um, it also can cause CNS toxicity, psychosis. Also, it is related to pyridoxine depletion. So we will give supplement of vitamin B6. So it also isolated reports of interaction with ACE inhibitors. Also, the isoniazid antagonizes sulfonylureas, causing worsening of glycemic control. That's why I only placed 1 plus for isoniazid safety. Next is pyrazinamide. I will also place plus 1 plus, because it is the most hepatotoxic first line drug. And remember, the patient has slightly elevated ALT, so we will be more watchful for this patient. That is why I placed only plus 1 for the safety of pyrazinamide. And ethambutol, I placed plus 2 because it is the least hepatotoxic among the first line drug. It can cause retrobulbar neuritis. Also, it can cause loss of visual acuity and red-green color blindness. So that's the safety of the first line drugs. For the cost, all of these drugs are free according to National TB program guidelines. So they should be enrolled with the treatment, and it will be given to the patients for free.